Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Everybody, welcome to Melanoma Matters. I'm James Larkin.
I'm Sapna Patel.
So today we're going to be talking a little bit about Tebentafusp, or Tebi, I guess, to its friends in uveal melanoma, and Sapna's going to take us through that. But before we do, maybe a warm-up icebreaker question. So I don't think I've asked you this before. If you weren't a doctor, what would you be?
We've had this conversation. Have we not recorded?
No, don't know.
I don't know either. Tells us.
Tell me the answer. We can always cut it out or something.
I would own a gym and a smoothie shop.
No, I don't think you told me that before.
No? I was an aerobics instructor in college. I actually probably shouldn't say this part. So I was...
I didn't hear that. Sorry, go on.
I was a step aerobics instructor, like a floor mat step aerobics instructor in university. I feel like I might have told you this story. So I always took an athletic course in college, just every semester, just to balance. So I was on the archery team for University of Texas, Austin. I'm looking to see if I have my trophy somewhere. I have a second place trophy from a women's tournament.
You're not looking for your bow and arrow.
Yeah, it was simple. I did simple bow and arrow. I did women's racquetball. I did tennis because I had done tennis growing up, tennis camps and stuff. Actually, this is quite humbling. I thought I was an okay tennis player, so I signed up for intermediate tennis. And I went to that college, course, whatever, showed up the first couple of days. And then the instructor, the professor for that course says, you need to move down to beginner tennis. And I said, no, I've played tennis before. And he was like, I'm telling you, you need to move down to beginner tennis. So, which is not the first time I've been humbled. I failed swimming classes and had to never really passed a swimming class. So one summer, and it was the summer that Princess Diana died, I took an aerobics class, just as my sort of biding time for the summer. And it was step aerobics. So that, those steps and you do corner to corner and all these things. And I guess it was just movements I hadn't really done. I was a runner, basically. So it was all these other muscles that I hadn't been using. And so I think it was a Monday, Wednesday, Friday course. Did Monday, did Wednesday. I'm not even sure. Do you remember what day of the week she died?
No. Oh, no, wait. Yeah, no, I do, because I was at a wedding, 1997. So I think it was between a Saturday and a Sunday, because we had the wedding on a Saturday and then we woke up the next day for breakfast and it was all. So I think she died about 5 a.m.
Okay.
On the operating table on a Sunday morning in a hospital in Paris.
I don't know even know if I knew that she went to the operating table. So that tracks, because I had done a Monday, Wednesday, maybe even a Monday, Wednesday, Friday that week. And, I don't know if you're like me, but if muscles haven't been exercised and I work them out, I don't feel it that day and I don't feel it the next day. But day maybe 2 or 3 after, I feel it. So all of a sudden, I think I had, in hindsight, now put myself in a little mild rhabdo, because my muscles were on fire. I could not move. And basically, I couldn't get off the couch. And my couch in college at the time was one of these wicker Papasan pillows that it's like a wicker basket and with a pillow and you fall into it. So then you're like a turtle trying to get upright, and then I was so stiff I couldn't move. And the TV was glued to, Princess Diana coverage. It was really kind of sad. So then I told the instructor on Monday, I said, I don't think I'm well, this, that, and the other. She's like, no, this is just, you haven't used these muscles and this is what it is to use them. Anyway, we became really close that summer. She was a triathlete, became pregnant in the fall, and then said, would you like to be my teaching assistant? Would you like to TA my course in kinesiology? It's basically aerobics for the semester. So I said, yeah. So then I was the main instructor because she couldn't do the power jumps and things like that. And this is when you had to wear the little belt with the lavalier mic, and then you have the, thing, and you're doing these, whatever. And We recorded those because they were courses, you'd have to record just for the university to see. So sadly, there is probably some archive footage of me teaching these.
So you don't have it yourself to share, no, the footage.
That would be so embarrassing if those ever surfaced.
So you'd have a sort of aerobic kind of gym.
Yeah.
And a smoothie bar so that everyone could carb load sort of before and afterwards, right?
Fruit, maybe. I mean, maybe it's more proteins. I'm getting more into protein shakes and the value of protein these days. And I don't know, I would have an aerobics bench in there for people that wanted to do certain calisthenic workouts, but I would be focusing on the lifting these days. Yeah, that feels like such a lovely life, to train your body 5-6 hours a day and train other people and smoothie. What about you?
Yeah, the CrossFit. What would my other career be?
Yeah.
But I mean, I think we have talked. I'd probably be a tree surgeon now because that just appeals to me in lots of different ways. I don't really like working inside, to be honest. Yeah, I'd love to be a tree surgeon. Very appealing. But when I retire, if I'm still healthy, I probably will open a gym as well, but a CrossFit gym. But the CrossFit people are obsessed by delayed onset muscle stiffness DOMS. And what the high risk activities for rhabdo are. This is like a whole subject of a podcast in its own right. But people talk about, eccentric muscle exercises giving you highest risk. And then certain things will cause DOMS at certain time points afterwards, like GHDs are a good example. Glute ham developer, which is basically a sit-up where you go all the way down. Anyway, we shouldn't get into that because it's a whole subject. All right, so that's great. No, we haven't talked about this here before, but you did tell me before about the aerobics thing, but it wasn't on a podcast. Right, so let's talk about TEBE in uveal melanoma, Sapna.
Okay, so TEBE in uveal melanoma, first of all, massive kudos to these investigators. This is the IMC GP100 202 study, and it's Paul Nathan, Jessica Hassel, Sophie Paperno, Newman in France, I think might have enrolled the most worldwide at her center. Just massive kudos to them for getting this done in a rare disease, randomized phase 3 trial, because we'll talk in a future episode about a phase 3 trial that basically had to drop the randomization because it was unsuccessful. So Tebentafusp is a first-in-class drug. We used to kind of refer to it as a bispecific molecule. I think now people like to call it, particularly the company Immunocore likes to call it an immune mobilizing T-cell receptor against cancer. So immune mobilizing monoclonal T-cell receptor against cancer, IMTAC. We'd also call these BiTEs, bispecific T-cell engagers. This is all to say it doesn't work like traditional checkpoint blockade. It's not a checkpoint inhibitor by any sense of the imagination. It's actually an antibody that recognizes GP100, and the other side of that antibody looking molecule essentially attracts CD3 receptor of a T cell. So it binds, it's maybe not unlike the way we think of antibody drug conjugates, except for the fact that there's no internalization and release of payload. It binds to something that should be expressed on the surface of a cancer and then recruits an immune response there. So that's really how it works. Because of this binding and recognizing in the context of MHC class 1, it is HLA restricted. So that HLA restriction here is for A0201 positive patients. That's a blood test that has to be done. You shouldn't test it on tumor for a number of reasons. Tumors can downregulate HLA status, but most importantly, your HLA status is germline. It's inherited from your mother and father. You have 2 alleles for HLA, and they just have to be genotyped. You essentially need high resolution genotyping to do it, because if you do low resolution, you'll just stop at the O2. You'll get A01, A02, A03, but you won't get that high resolution. And this has to be A0201, so high resolution positivity. Patients here were randomly assigned 2-to-1 to Tebentafusp or investigator's choice. And the investigator's choice treatment was single agent Pembro, single agent ipilimumab, or single agent dacarbazine. It's probably
So,
worth.
so can I maybe stop you there? And so the investigator's choice was specified. In other words, investigator's choice of, or was it true sort of investigator's choice? Investigator's choice
of this menu of three. Yeah, Pembro or Ipi or dacarbazine. And probably worth mentioning that we now have many, many trials in uveal melanoma that show that dacarbazine has a 0% response rate. So, good that they had an option to not just have dacarbazine as their one choice. The Summit trial is one that comes to mind, and some others that have been done where the control just was dacarbazine. But kind of a pity that we're still putting that as our control. But that's all changed. You'll no longer see, hopefully, a randomized uveal trial using dacarbazine as control, because now we have gold standards. So single agent pembro.
Yes, you're probably going to come and say it. So I was going to ask you about the checkpoint inhibitors, single agent as standard of care. What do you think about that?
So that was the real controversy, and this is what held a few sites. Certainly, it held us back in the at MD Anderson at the time. We just didn't really feel good about Pembro or Ipi. Ipi's response rate is a little bit higher than single agent Pembro in uveal melanoma, and we think of that as opposite in cutaneous. We think of single agent Ipi having a lower response rate than single agent Pembro in cutaneous, but in uveal it might be the opposite, about 5% response rate with Ipi and maybe 3% with Pembro. So single agent checkpoint inhibitor is pretty wimpy response rate, but combination checkpoint inhibitor, which we'll hopefully talk about, is moderately strong. No, that's not the right word. It's certainly more than single agent, single digit response rate, we think, although maybe not in West London, you tell me. So this is all to say that comparator arm, the investigator's choice arm in the Tebi trial, is good that they had an option, but there would be some consideration, was it the strongest option available? And we can talk about it when we discuss it, because there was a propensity analysis done. What if you had used Ipi-Nivo as the comparator? So just something about Tebi, there's something called step-up dosing that happens. What else should I tell you? So this is randomized 2-to-1. They ended up, this is a global study, first of all. So great that it was done really around the world. Primary endpoint was overall survival. And that's important because, you really couldn't use something like PFS or objective response rate in this disease where those things tend to be short and low. So overall survival really would be your marker of, is this benefiting? Let's see what else. In the phase 2, there was some consideration that patients who had onset of rash in that first step-up dosing period, really maybe even that first dose, were the ones who had a benefit in overall survival. So they took a little bit of their alpha from overall survival and spent it on this rash analysis. And this was to look and see, if you developed a rash, were you more likely to have a survival benefit or not? So we can talk about that in the results. It was kind of an interesting, albeit controversial, I think, as you and I both know, analysis that ended up adding and amending in their protocol. So this study had 442 HLA-A*02:01 positive patients screened, and 372 ended up being randomized. So 252 to the treatment arm, 126 to the control arm. It is interesting that they're saying that among the patients who were screened who didn't undergo randomization, it was due to not meeting the inclusion criteria. And it's interesting to know, I don't have an answer for this, but I'm sure it's in the supplemental. Is it because they didn't have the right HLA or another inclusion criteria? Majority of these patients, 82% that were randomized to investigator's choice, took pembrolizumab. So this is really a study of Tebi versus Pembro, but 13% received Ipi, 7% received dacarbazine. And we've talked about this before, that even those small subsets in a comparator arm can kind of derail a result. If I guess more, I should say, could in theory derail a result. So if 20% of this study 18 or 20% was receiving something other than Pembro, and Pembro was actually a real competitor to this drug, that 18% could have watered that down in theory. But I don't think anybody believes Pembro was really, the strongest contender here. 36% with an elevated LDH above upper limit of normal. And that's all the cutoff they did. I don't see that they did a 1.5x or 2x as we had talked about. And then importantly in uveal melanoma, and we should always pay attention to this in a demographic table, we should make sure it's being captured this way, and we should look for it in a demographics table. Uveal melanoma AJCC criteria is not the same as cutaneous melanoma. So M1A, M1B, M1C, they mean something different in uveal than in cutaneous. In uveal, it means the size of your largest metastatic tumor deposit. So an M1A is less than or equal to 3 centimeters, largest tumor deposit diameter. M1B is 3.1 to 8 centimeters, and M1C is anything greater than 8.1 centimeters. If you had applied that cutaneous criteria to uveal, because of the predilection for liver metastasis, these would all be M1C patients, 90% of the time, and only 10% would have extrahepatic only. So you just wouldn't be able to see real differences here. But when you cut it off by this tumor burden size, it really starts to make a difference. We've sort of seen that similarly in skin melanoma trials. And here it's good to know, this is a frontline untreated metastatic uveal trial. 55% of the patients, 56% were M1A. So they were of that smaller volume disease, which is great. Good to catch these patients early. Maybe it'd be nice to ask Paul Nathan and the investigators, do they have the median tumor size of that M1A group? So was it trending towards the 1.5 centimeters? Or were these people who were really closer to 2.93 centimeters? And this matters maybe in a future discussion of why we might see different results in different practices. If you hold on to these patients from the ophthalmologist and you're screening them closely, maybe you're picking up disease when it's smaller. And anyway, there might be just even a slight spectrum there, even in the M1A group. A third of patients, 37% in both arms, were this M1B, and very few patients, only 8% in both arms, were M1C. So these really large tumor burdens. I was looking to see if I had a ruler here, just to sort of like approximate what 8 centimeters looks like, but I don't have a ruler in front of me, so I can't show you. I have calipers somewhere I could probably pull, but
it's just over 3 inches, isn't it?
Yeah. It's just a conversation about size with you can't. Okay, let me move on to nothing else in demographics, I don't think. It is also good to talk about the location of tumors. 90% will always have liver involvement. So if you look at hepatic only, so it's only confined to the liver, that's about half the uveal population. So that's reasonable. That's what they had in the study. Extrahepatic only, very limited number of cases here, really 9 patients or 4% in the Tebi group, 10 patients in the control group, 8%. And then what about patients who have both liver and something else? About 44% on both arms. So taking a big step back, how many of these metastatic uveal patients have liver involvement, either liver alone or liver plus somewhere else? 90%. It's 90%. And then that's really it. A small number of patients had previous surgery for their metastatic disease. It's not a common approach, although it can be commonly used in Europe as a life prolonging strategy. So the money shot and the money takeaway here is that Tebi does improve overall survival in this frontline setting when compared to a majority pembrolizumab receiving population. There was an improvement in median overall survival from 16 months to 21.7 months. That's a hazard ratio of 0.51. Amazing to see a hazard ratio like that in uveal melanoma. Who knew? And the hazard ratio is very striking. No real difference in PFS, although the hazard ratio there is still significant. It's 0.73 with the confidence interval that does not cross 1. But numerically, it's a difference of 2.9 months to 3.3 months.
So reason do you think for the disconnect between PFS and OS? Is that the difficulty in measuring the disease? Is it something to do with the characteristics of the treatments, bit of both?
Well, it's both. We've seen this in some other cancers. We saw it with sickle T and prostate cancer, this uncoupling effect, not tremendous amount in terms of PFS or response rate, but some sort of uncoupling. How does it lead to a survival benefit? By the way, that's why it's so important in these studies that either the big sites or the industry sponsor themselves ask some of these mechanistic questions and help fund some of the biopsies, because you want to know if you're not changing PFS, is it because this is just a disease where we have a hard time radiographically measuring it? And we know the short answer is yes. This study looked at ctDNA correlates, and it turns out a reduction in ctDNA by week 9 was an indicator that you were likely to respond. And it turns out majority of these patients were having a reduction of some sort in their ctDNA. But that's not routine practice. What platform do you use? Can you get ctDNA covered? So all you have to use is your radiology. And if we think radiology underestimates the benefit, then it's not about tumor shrinkage. It's about, hey, look, we think it's going to make you live longer. But what is that mechanism? And it's hard to know, target engagement, T-cell recruitment. It's really hard to know in the absence of tissue-based biopsies.
So when we went back and listened, we thought that had gone a little bit longer than we anticipated. And so we've decided to split into 2. And that's the reason that at least Sapna, you've changed clothes. I may not have. But anyway, the point is that was great. Thanks for going through all the data for Tebi and uveal melanoma. And now we're going to have a separate podcast and we're going to talk about what that means in practice and a few other things. So thank you.
Yeah. All right.